Hello and welcome to webinar series. Myself Shanti, and as we all know, World Patient Safety Day activities are ongoing in every hospital setup, and also in terms of awareness, we are here to discuss the topic on prevent harm by owning patient safety. Yes. Now I request all the speakers in the panels to introduce themselves. Firstly, we like to hear from Dr. Sunita ma'am. Over to you, ma'am.
Good afternoon to one and all. I am Dr. Sunita, Principal Government College of Nursing, Hyderabad. I am happy that I got an opportunity to participate in this webinar and thank you for organizers for giving this opportunity.
Yes, Kuni, you're there.
Very good afternoon, respected madams and all the dear audience in this webinar. This is Dr. Queen Mary. I'm working as Senior Nursing Officer in ESIC Medical College Hospital, Sanat Nagar, Hyderabad. It's my greatest privilege to be a part of this webinar. Thanks a lot.
Good afternoon, everyone. Here, Mrs. Talapalli Roja, and I'm the nursing superintendent from Azara Hospitals, Warangal. And it's a honor and a privilege to be part of this discussion today. And thank you for the organizing team.
Good afternoon, one and all. I'm Premlata. I'm working in Yashoda Hospital, Somajiguda, as a senior nurse manager, and I got 25 years of experience, and I'm happy to be a part of the discussion.
Yes, so that was very wonderful discussion, and I'm privileged as well and honored to be associating with you all. And let us see what we have in, further discussion. Yes. Firstly, we like to hear from Sunita ma'am, like as the international theme for World Safety Day is been declared as safe care for every newborn and every child, and it must start from all of us, as the neonatal mortality and morbidity rates are very high across the globe. Yes. And why safe care for all children? We like to understand from ma'am. And yes, ma'am, over to you.
Yeah. So yes, according to the theme, because why newborn and children face disproportionately high risk of harm in healthcare, especially mostly in ICU, surgical settings, and during while giving medications and at medical administrations, etc. So the main this group are they're depending upon the caregivers, because for the caregivers they are depending upon caregivers for their survival growth or healthy development or for their basic needs, nutrition or emotional support, etc.
Yes.
And also they are more prone to get infections. Why? Because they are their immune systems are still in developing stage, leaving them less immunological memory and fight of germs. That is, and also bloodstream infections. If they admitted nosocomial infections, streptococcal organisms, which they got infections. These are more prone to get infections because of their compromised immunological system. And also medication errors. Medication errors are there are so many medications errors which can occur, like while dispensing incorrect medications or dosage or miscalculating the doses because they are children and neonates. The calculation is must. So miscalculating the doses and failing to identify the drugs and drug interactions and contraindications, etc. And when administering, we have to identify right. There are 5 rights, like right patient, drug, time, dose, route, etc. And may not be, and fourth one is may not be able to effectively communicate because there's a language barrier. As well as we have to, the caregivers has to identify what child needs by seeing their gestures or by their body movements, etc. We should identify. These are the main. That's why we should take with safe care for all children. That's what this is the theme actually given. These are we have to.
Yes. Very, very, very productive insight you have provided, ma'am, as my specialty is child health. Yes, communicating with the newborn and the infant remains the challengeable criteria for bedside nurses, especially when the child is very sick in NICU or PICU. Yes. Going forward, again, we like to understand, we have very beautiful, practicing about this setup about this IPSG goal, which is nothing but international patient safety goals. And right from a decade back onwards, we are just practicing this. So, Queenie, like I would like to understand from you, like while practicing these goals, are we not, you know, doing enough to identify patients' risk and associated likely harm? Yes, over to you. What is your gist on the
Yes,
same?
ma'am. Yes, ma'am. According to JCI accreditation, these are the following goals which are designed to improve the quality of care and also to reduce the risk of harm to our patients. So
Yes,
mainly here we have to focus on the assessment and monitor and prevent the adverse effects of the indicators. So I would like to say the mainly we are categorizing the indicators into three main areas. That is patient safety indicators. We have the second one care process indicators and the third
yes,
health outcome indicators. So coming
yes,
to the first one, the first criteria is the post-operative complications in patient safety indicators. So that is the prime one. The later
yeah,
followed by accidental falls, accidental punctures,
yes.
any lacerations on the patients while doing or performing procedures, death, that is especially the preventable kind of deaths, hospital falls, pressure ulcers, birth trauma, foreign bodies left over
So
in
one
the
minute.
patient
So one second, I would like to interrupt you here. Who presents this indicators? Do you
indicators.
present? Does your subordinate presents, or how do you, map this indicator? Do you have any
So
mechanism?
yes, we have a software database which will be having all those indicators are mentioned in that. So we will be filling and we will be assessing all these kind of indicators, and we will be filling and we'll be submitting to our auditing team. So we
Yes,
have every hospital which is almost everything is NABH accredited and JCI accredited few are. So we will be having those things recorded and rechecked and assessed, and we will be going and checking continually. We'll checking them, and we will be doing our processing so that the outcomes will be better in the patient care. At the
yes,
end, our patient should be safe. So with
yes,
all these indicators and all these nominals, whatever we are entering the databases, will give us a very clear and clear idea and clues to identify where the problem is, and we can project and we can focus on the problem and reduce the instance of infections, all these
yes.
problems. And
So
coming to the
every,
care
just a
process,
minute, just a minute. Every hospital has this beautiful quality indicators in terms of nursing quality indicators, patient indicators, like in terms of IPSG goal, as you said, that it is presented every month and it is analyzed and it should be validated.
yes,
Without validations, we will never understand where we are
yes,
standing and what improvement compliances we should adhere to. Yes, so very valid insight you have provided. I'm sure we like to see your indicators as well sometimes when we visit your setup or you visit our setup. Yes, thank you for that.
obviously,
Yes,
yes,
and yes, IPSG goals are very challenging because now JCI guidelines have just given us six,
yes,
indicators,
patient goals,
and
Yes.
we do have lot of other quality indicators in terms of nursing quality and patient quality indicators as well.
Yes.
Now, we like to understand from Roja, like which goal is often challenging, or so far you have improved at your setup,
Yes.
or what is your, practice at your setup? Yes, Roja, over to you.
Yeah, the question is quite challenging, first of all. So, all our
Yes,
PhD goals are very much challenging. We may not be reaching 100% compliance. So, it is a journey where we will escalate the graph forward. So, I would say, like, there is quite in our setup in our other hospital, we have improved the goal number one with two identifiers, that is a universal identification bands and also ID bands, ID bands and also the UHID,
okay, which
unique
one is
identification
challenging?
number.
Which one is challenging? Which
Quite
goals are
challenging is
challenging?
I would go for three. So improving the safety of highlight medications is quite challenging here.
Yes,
Even for that, we have developed a mechanism for indenting. Like if we indent our drug, highlight drug, the pop-up will come in red color. So the nurse will be
yes,
alerted and the dispensing pharmacist will be getting alerted. So this is how we have developed the mechanism of taking extra caution for the highlight medications. And still
yes,
we have to improve in other IPSC goals also. So I
yes,
would say all are challenging, but we have
yes,
improved for one, two, and hopefully five also. So we may be reaching the goal for four, three, and six in future.
yes.
And
Very good.
anyways,
That is,
Consistency is a key, what I would like to say. So
Yes, yes.
these are all are complex. When the consistency is maintained, we may be able to reach the more
Yes, as
compliance.
yes, as very rightly and real-time experience you have provided, you may reach to the compliances with other indicators, and consistent practice is the prevention for the same. Yes, very valid insight. As yeah, going forward, this is again very challengeable slide. I think I must give the slide to Prema for her view. Has surgical safety compliance improved?
Yes,
Yes,
ma'am.
Prema.
If I take surgical safety compliance, it has improved a lot, ma'am. Right from
Yes.
the preoperative area to the once the patient comes inside, enters the theater, it is quite challenging, right? If you
Yes.
take in the preoperative area, whereas the surgical site marking and it has to be done in the preoperative area. So
Yes.
before we used to have a challenge. Right now, it is like consistent practice, ma'am. So everybody has to go, the doctors has to come and do the surgical side and side marking, and they have to take initiative. Now we don't have like we are not facing much problem, ma'am, because everybody has got awareness and the doctors are coming forward and marking the site. And
So,
in drop also we are following surgical safety checklist, whereas it is a tool which is designed to ensure safety before, during, and after a surgical procedure.
so
And
you are being empowered enough and authority has been given to you. You mean to say you can directly tell the doctor, doctor, you have not done. Would you mind doing? And then only I'll let you out.
yes, ma'am.
This you want to communicate?
Yes, ma'am. Definitely, I would do that.
Hopefully.
I will
Yes.
definitely go to the doctor and tell, sir, this has not been done. The signature is not there, not there, and the consent you have to you have to sign, and the side and side marking you have to do it. And a timeout procedure is a little bit challenging, ma'am.
Yes.
Whereas everybody faces it. So some initiative has to be taken for that. So we are doing
Yes.
that, and I'm also empowered to speak to the doctors regarding this.
Yes. Yes.
And
So, as yeah, we were discussing before that every hospital is not, every hospital has got its own complex needs and challenges. As you rightly said, timeout is a complex criteria. But as Roja was mentioning, consistent practice, reminder, diligent audit, and communication is the key. We must not feel bore out of saying that I'm reminding, but they are not doing, etc. Yeah, nurses are being empowered even by the owners of the hospital. So I think we must lead this challenging indicators. Yes, very valid discussions we had on the same. And yes, now what is the mechanism for tracking this IPSG goals or patient indicators? Like, what do you think, Roja? We should have nice mechanism, 1, 2, 3 few mechanism. What mechanism do you practice at Razana?
Yes, ma'am. Like what we follow is a bedside rounds. We have the audit team and then we have a quality nurse who does audits regularly and taking the checklist and side bedside rounds. So bedside rounds is a very much valuable thing where we will track the data and prevent the early risk. So
Yes,
that is how. And the audits and surveillance we do, and it is the only tool we will get the compliance rate and the non-compliance rate. The perfect
yes,
checklist is maintained, and through the audits and the surveillance, we come to the non-compliance and the compliance, and we do the RCA and CAPA for the non-compliance. And all you, as you all know, incident reporting system, like in an open talk, I would say many people hesitate to come and report the
yes,
incident. They
yes.
feel like it's like a punishment, or I will be given any
You'll be
punishment.
questioned.
Yes.
Yes, yes,
So for that, we have developed a mechanism that which department gives more number of incident reports, we give the award for them. So that's how our hospital has been improved in reporting the near misses event.
yes,
So
yes,
that's how we motivate the nurses over here. Not only nurses, the technicians and who all fall in medical
everybody. Yes,
team. So we have motivated them and counseled them to report the incidents earlier. And we have good team running, quality team who is working on it. The process is very quick in Azara hospitals. We take the action and we prevent the errors in future.
yes. As you said, I would like to correct you here, if at all, or maybe I would like to just give my statement that the notifying the error and writing the incidents and RCA kappa is not only the job of quality nurse or quality department. I think every hospital employee should be empowered enough to just notify the incidents or report. Yes, I think having so much of enriched experience with Sunita ma'am, I would like to even understand from you, ma'am, because you assess a lot of panels and a lot of theses, dissertations, and you've been into the clinicals. So while these nurses do not self-report, as Roja was saying, she has got some mechanism. We also have our mechanism. What do you think? You see,
Self-reporting, because for this is actually we have to create awareness on behalf of the nurses, because criticizing will be present. If somebody has done some mistake, the peer group will criticize. The stigma itself, they will not come forward to report. So that should be avoided. We should give awareness, because the importance of reporting is immediately reporting is much more, so that we can take the precautions to further not to get any harm. So we should create awareness first, education to be given, how to come forward, as early as possible. When the incident occurs, that should be reported.
Yes. So, as you rightly said, the art of communicating with the fresher nurses should be, to be done with a lot of trust and a lot of, confidence should be given. Nothing will go wrong if at all you notify the signs of phlebitis or patient near miss fall. Patient did not fail, but if I, do not take the measure, patient might fall, etc. Yes. So, going forward, we like to again understand from Queenie at her setup, what are the simple steps? Now we are talking about owning patient safety, as how we own our gadgets or accessories, our attire or our money or anything else. So we should also own the patient safety, whatever, however the patients are being assigned to the nurses. Yes. So Queenie, what is your take on this? How should we own the patients or patient safety?
So it's as very simple. So first we have to get identified, like we should know about the patient. We have to know their past history, present history, complete case details. We have to get informed, and we have to know, inquire and find out and read and get aware of entire details about the patient. First, that is the prime factor we have to consider. The second one, based on the history, we can identify the potential risks. And for example, any seizure patient, so he's prone for falls, so we have to take the fall prevention measures.
Yeah.
Then follow pathways. So I would like to say it is a clinical pathways, like for example pre-hospitalization pathways, discharge pathways. There are different kinds of pathways based on the condition of the patient.
Yes.
Then observe carefully and monitor the patients very closely, and report incidents. If anything happens, report them promptly.
Yes, I think
So
very valid insight. Yes, if at all the audiences or viewers, if they understand these are the few parameters, if they
yeah.
follow practicing, I think they will always take the ownership and govern the patient safety in terms of, complication, to avoid the complication. Yes. So, yeah. So again, there is one question, anytime you say patient fall or any medication error, the nurses say we are responsible. Yes. So I would like to ask Roja, like who all are responsible for patient safety? Not only Roja, everybody will have their own view that, who should own the patient safety, who all are responsible for patient safety.
Ma'am, this is not only one person or one man show. Like from the entry gate till the exit. Means when the patient is entering into the gate, starting from the security, housekeeping, and the helping staff or paramedical technicians, who are all involved, who are under the roof of Azara or any hospital, all are responsible for the patient safety, I would say. So since the nurse is attached to the patient 24/7, maybe the nurse will play the crucial role in patient safety. But I would say all, including all doctors, nurses, technicians who are under the roof of one hospital, from the time of admission to the discharge desk and out of the gate, I would say. So all are responsible, equally responsible for the patient safety.
Yes. And they shall be they shall be owning the patient safety and hold accountability as well. Yes. So yes. And yes, if at all you want to see that your patient is safe, the third goal remains still challengeable because we have multiple, subclinical medication errors like low dosage, overdosage, omission of dosage, strength, all etc. So basics of medication safety, as Dr. Sunita was mentioning, that right CDC has approved now 10 rights. Even here, patient should be rightly assessed as well or rightly evaluated as well. So WHO and CDC combined goals everybody should practice. Yes, and nurses' challenge remains same in terms of handling or administering high alert medication. So I would like to ask, Roja, like what is or Queenie, what is your practice? What is your practice for cross checking? Like before your nurses administer, do they go through the prescription? If they don't understand, do they ask the doctor? Do they cross check? Sometimes they say no, there is no senior. What is your practice? Yes, Queenie.
Ma'am, we do have more concentration, pay concentration towards high risk medication dispensing or administration and documentation too. So always the universal protocol in the all over the world we follow is a double checking. So that is the main important criteria and which will prevent the errors a lot. So first double checking, verifying with another person, read back policy. So if it in case of verbal orders, the read back policy also we do follow, which will prevent the errors, and verifying the orders, checking the drug chart, and also the consultant order. Sometimes there may be some transcription errors also, so we will cross check with the doctor's sheet and the drug chart. And dosage also we have cut down the abbreviations also, because units means they will write U, and
Yes.
mg means they will use another abbreviation. So
Yes.
our team has completely deleted, and we have completely stopped writing all the abbreviations. So that's
Yes.
how we are preventing the errors with the high risk medications especially. So, and the storage part also we are doing according to the manufacturer's recommendations. And this is how the double checking is the main key where it will prevent many errors, ma'am. So
Yes.
we follow the double checking method, and on addition to that, verification of the medication orders and also the consultant prescription notes.
And as well, the physical audit of the medications
yes,
which
ma'am.
is kept in the patient bedside in the nursing station,
Yes,
because
ma'am.
it has to be verified. Yeah, what has been procured from the pharmacy, etc. Yes,
Yes.
that was a very beautiful discussion. I think we are just close to the end of the discussion, and this patient safety is a very, very big subject, and it cannot be just summarized in 15 or 20 minutes of time. Yes, we are here for ma'am's update on how we all should inculcate these few preventive steps. I know there are many preventive steps, accreditation laws like JCI, Nursing Excellency, and NABH guidelines, AHPI guidelines. We have been following it up, and in-house protocols. But yes, few insight which you like to tell to all the nurses here. Over to you, ma'am, and then we end the session.
Yeah. So to prevent these medication errors, we have to double check and verify. So
as Roja said, yes.
Yes, yeah, Roja said. And also next, clear handovers at bedside. So the nurses, when we give, we have to go to the around the bed. We have to take a bedside handover regarding
yes.
lab investigations or medications. What is the present condition? What has to be pending? What is there? When the timings, everything we have to hand over after going to the bedside. Then only we can easily have taken over and document accurately. So whatever in the shift duties, whatever the document is very accurately to be documented at the bedside chart and in the patient case sheet. That is regarding even investigations or IV fluids, lab, anything pending document, so that is easy to follow by next health personnel.
Yes.
And seek clarification. Is there if there is doubts? No, you can clarify with that with the other healthcare professionals. OGT and bedside, that is nothing but on job training bedside. So this is very helpful in hospitals or in clinics where the trainees learn practical skills directly on with the patients under the guidance of experts or professionals, experienced professionals, so that this is hands-on learning of OGT bedside, so that they can improve their skills and report miss errors as well. If there is anything that should be immediately reported, as we discussed previously.
Yes.
Yeah, that should be reported.
Yes, few preventive. I think we have just tried to tell you, nurses, that these are the very preventive, crucial steps which everybody should practice. And do we have any other doubt or to be anything to be asked? We can always, discuss here, and otherwise we end the session. And yes, I request everybody just to share this session, and furthermore, we will connect. And I thank everyone for your valuable time. And we end the session. Thank you so much. Anybody has any word to say?
Thank
Thank
you.
you
Yeah,
so much, ma'am. It's really a very great opportunity to meet you all on this webinar. And the
yes,
topic you have chosen is very great. And yesterday was the day, 17th September was the day.
yes.
So you have selected a very good topic ahead. Thanks a lot, and thanks to you for organizing such a wonderful session today.
Thank you. And
It
yeah,
was
we'll
very informative
connect
also.
further. Yes, we'll connect further. With one session, we are just not ending up. We will again further connect. Yes. Thank you. And thank you, Sunita ma'am. Thank you, Roja. Thank you, Premalata. And thank you, Queen. And we end the session.